Here to speak to us on connecting consumers to costs, ready or not, here it comes, is Dr. Bob Galvin, CEO of Blackstone's Equity Healthcare. Please join me in welcoming him to the podium.
Well, thank you, and hello. Are y'all ready for something completely different? Because you've heard some great talks, and I have liked them very much about how you connect kind of, I think, patients to doctors and doctors to patients and patients kind of to their own health. And what I'm going to talk about more today is the cost side of things, which is this connection thing is also going to work on the side of having patients and people that aren't sick yet and our consumers figure out how they ought to choose healthcare. So I think the revolution we all agree is coming. It's probably here. I think that you have heard some great stuff about the other side. I don't live in this space, and so that introduction, you probably have no idea what the company I run is. I work on the employer side. And I worked at General Electric for a long time, not in the imaging business, but on the corporate side, managing healthcare costs and doing healthcare policy for them. So the issue at GE was 300,000 employees, almost 1 million covered lives with retirees, $3 billion of spending, and how did you get the best out of the dollar? This company that Joe mentioned when he was up here, I've been doing for about a year. It's actually now 35 companies. Companies like Neiman Marcus and Hilton, et cetera. So my company goes in and does essentially the same thing, which is to say, well, in aggregate, you guys are all spending about $1.5 billion or $2 billion. How do you know what you're getting for that money? And how do we figure out how to get more for the money? So it's really the other side of connecting. So really the kind of stuff that you've heard already is going to continue to go on. I'm on the side about trying to figure out how do we control this cost thing? How do we use connection? And I'll talk about in the next 19 minutes or whatever I have, why we're thinking on my side of the fence about why you need to do this. What does consumerism mean? How does connection work? And what's it all going to look like? So I think employers are going to drive this. Just a brief healthcare 101. You might not need it about who employers are and what they do. We're unique in this country. I think everyone knows that, is that employers and their employees pay first dollar. And as much as we all focus appropriately on Medicare and its 45 million covered lives, because it's a single buying entity, there's 160 million people covered by employers. So it's a very big kind of block. I wrote a couple pieces that you can see to the left about trying to figure out what the heck our employer is going to do. Frankly, we have not done a very good job about trying to figure out how to get value out of healthcare. But I think when I travel around and talk to other employers and talk to the leaders of these companies, this is what I see. And so you wanted to ask me what the top 3 issues were when you talk to employers. They would be cost, cost, and cost. I think if you go to Washington and you ask kind of the policy people, what do you think is going to happen with employers, I think they'll tell you, well, as soon as these exchanges come in 2014, and particularly in 2017 when the states will let larger employers in, everyone's going to exit and employers are going to go to these exchanges. I'm a complete contrarian on that. I have a blog, and I wrote a blog piece about it. I just don't think that's going to happen. I think employers would be happy to exit if it was in their economic interest to do so, but I don't think it's going to be. So I think employers are going to kind of be stuck with trying to figure out how to manage this cost problem. And I think the big strategy for at least the next decade is this thing called consumerism. And if you roll back in history a little bit, it really was kind of a lot of benefit design stuff in the 80s. The 90s was really managed care. This past decade, the aughts, were really about disease management, health promotion. That's going to continue. All of those continue. But this new deal is really about consumerism, and it's going to take the forms that you see there, like them or not, and I'm going to talk about them in the next few minutes and what this all has to do with connection. But it's this idea of these high deductible plans, people paying more of their own dollar for coverage and getting them information. And so the question is, why? And so, why go there? And kind of this is, the next few minutes are kind of the conceptual framework for why employers are thinking the way they're thinking. And so these are some interesting slides, and this basically just says, the percentage of healthcare costs paid by consumers has dropped dramatically, and you can see the slide fill in. So there is this idea that when it comes to making healthcare decisions that cost money, people have less and less a stake in their decisions. Now, all of this stuff is pretty controversial because there's plenty of very smart people that think that when it comes to healthcare, people ought not to have to make buying decisions. So I just ask you to bear with me and listen to the reasoning, not necessarily agree with it, but I think it is a trend. I think it's going to impact the stuff you do. But this is the basis of it. The basis of it is, if that's the case, then here's what happens in a paternalistic system. If you're not paying and you're frequently not engaged, and I think any of you that deal with patients, and I am a physician and I am a clinician and I still see patients, how difficult it is to get people engaged with their health. I don't know if the fact they don't not pay much for it is part of it, but it's one theory. And so this is kind of what we see on the employer side. This is what happens if you're in a paternalistic system. You don't think there are big differences in quality between doctors and hospitals because doctors wear white coats and hospitals look good. You don't think there's much you can do about changing your health care, and you think the more the better. And so one parable I like to tell is this one, and so you all recognize him, and I don't know how many of you know this story, but basically after he got out of office, President Clinton had heart disease, went to an emergency room up in Westchester County, got well treated, and was told that he needed bypass surgery. It was not emergent. He had his choice of hospitals. And it turns out that at the time he made the decision, this data was sitting out there on the internet. This data is New York State data. It's actually very well. It's done by physicians. It's kind of well vetted. The risk adjustment is as good as we have, and it shows this thing, which is really the kind of risk-adjusted mortality rate or the death rate, or basically how many people in 30 days won't be alive. So obviously, this is like, for the baseball fans, this is like an earn-run average. Lower is better. And so somehow, faced with this data, with someone as brilliant as President Clinton is, he ended up going to Columbia Presbyterian, which, as you can see with the asterisk, at that time was statistically significantly worse than Cornell. Those of you that know New York City know that you're not talking about traveling 85 miles through a snowstorm in a prairie to get there. They're very close to each other, a couple of miles apart. So the question is, why would someone this smart, who obviously kind of is very engaged in his health, not choose the hospital where he had the best possibility of coming out with a good outcome? And there are actually two theories that explain it. The first theory is that despite this data being out there, he never saw it. He never knew it was there. He wasn't aware of it. He had no idea. And secondly, his physician didn't know. His physician did what physicians do, which is, I train there. I know the surgeons. People do very, very well. I think you're going to be great there. And I believe that's how the story went, and that's how President Clinton ended up where he was. Now, there is a second theory about why President Clinton ended up going there, and that is, although he never saw the data, actually Hillary did, and he ended up going there. So there is some consumerism already going on in healthcare. But so one idea is that, if the data's there and it was, the connection was possible. I mean, if you've never been on this website, it's about 3 to 4 clicks. I think it could be a lot better. It could be a lot more user-friendly. But it isn't very difficult to find, nor is CMS.gov in the hospital ratings. But if people aren't compelled to go to them, kind of what good did they do? If you go back to the second thing I mentioned about people just think that bad things happen to them, we have been fighting this obesity epidemic so hard for so many years, and I've done it with so many patients, and we have been so unsuccessful that you have to wonder if there might be something about getting someone more involved in the cost of the care that comes about as a matter of the obesity that might make a difference. And I used to show a slide that everyone shows from the CDC about how rates of obesity have increased. But this one I like better, which is essentially what would happen, if Michelangelo as David came to the U.S. and lived in our system for 2 years. He'd look like that. And so, we've been fighting this obesity epidemic, and we have been connecting people, and I love this connection stuff, and I think some of it will work. I think it's necessary and not sufficient. I don't think anyone knows what the sufficient is, but one thought might be that the sufficient is getting people more engaged. So When I think what it's like as an employer-payer trying to manage the healthcare system, I think about not only obesity on a personal level, but I think about what the healthcare system has become and what it feels like being that guy. I'm the little guy trying to push the healthcare system. So this consumerism stuff, this idea of connecting people to cost and price, comes from this idea that kind of excellent medical care is absolutely necessary. All this connection stuff is terrific. Convenience is going to make a big difference. But is it sufficient? And do we have to get people less disengaged from what it costs? And that's really the theory. And this is kind of a second parable. It's a tale of the brand generic. I think any of you, I don't know if any of you kind of work in benefits, but you're all employees, or most of you are employees. I bet most of you are covered by health insurance. And if you are, this stuff that goes on when you have a certain amount taken out of your paycheck, and then you have to pay a certain amount when you go to the drugstore and see doctors, et cetera, et cetera. Well, you know, the science of incentives and the science of how people make decisions, this kind of interesting growing field of applying behavioral economics to healthcare, begins to show that people are somewhat irrational about how they make decisions, but they're predictably irrational. Well, it turns out when it comes to something like drugs, they're really rational. This was actually something that came from when I was at GE. And so at that point, we kept trying to get people to go to generic drugs. And so about 50% at that time, it's now about 60 or 65, but at that time about 50% of drugs had generics. But no matter what we did kind of for those generics, and we should have had everyone go to those generics, we could never get more than half of the people. So for 100% of the drugs where there was a generic, only half of them would go. So we did health fairs, we begged, we wrote communications, we did everything we could. And then we said, aha, maybe we can treat healthcare like something else, because I mean, I just think there's a take-home lesson, which is, you know, in the U.S. we might or might not be interested in the health, but man, people can shop. And so what we did was basically said, you know what, it's your choice. We learned our lesson from managed care. We were no longer going to say you can't. We're going to say you can do whatever you want, but if the generic is available, and I can get you a cholesterol medication that's just as good, and there's a generic available, and that's 50 cents. And the brand is $3 a day versus 50 cents a day. You can do whatever you want. We're going to pay the 50 cents. That's called reference pricing. So what happened is, within 2 months, the 50% of people that chose generic when it was available went to 95%. And so it is some lesson about the fact that people do make rational decisions, at least in some parts of healthcare. And I'll get into a couple slides that show how careful you have to be about applying this to things that are more complex. The other thing that was interesting is suddenly people started saying, what's a generic? And so the interest in understanding what was going on in healthcare increased. So let's do a quiz now. I don't know if anyone here is old enough to remember the show The Price is Right. Does anyone remember the show The Price is Right? I was really embarrassed because I figured if I said that, no one knew what I was talking about. Maybe it's in reruns on cable. Anyway, there used to be this great show, The Price is Right, and they would show these appliances, and people would be jumping up and down in the audience if you named the price you won. It was really dumb, but it was kind of fun if you were sick at home watching TV during the day. So basically, let's say you need an MR scan of your shoulder. You saw a physician, this was the appropriate diagnosis. You really needed an MR scan of your shoulder. Well, it turns out that maybe you're just paying either nothing, or maybe a $15 copay, or maybe a $25 copay, but that's all you're paying. So the question is, how much does that actually cost? Because remember, your employer is paying first dollar, and by the way, it's coming out of your paycheck. You know, employers don't actually pay for this. They actually pay for it and then give you less of a raise. So you don't know it, but you're paying for it. So the question is, if you go to one of the wonderful hospitals around here, I trained in this town, if you go to one of the hospitals out here, how much is an MR scan of your shoulder? It's Price is Right. Come on, how much is a refrigerator? It's $1,500. That's very close. It's $1,200. Now let's say that you now basically have a deductible, and you have to pay the first $600. And that's $1,200, so you're going to lose $600. And someone says, you know, when you drive by and you go on the Storrow Drive and you kind of say, you know, there's some imaging centers around here. And you find out, wow, there's an imaging center. It's the same scanner. And by the way, you can find out it's actually the same radiologist who read it under a different billing code. How much do you think it is at the freestanding imaging center? Hey, you win. $600 is the difference. Same scanner, same reading. So the question at the end of the day is wouldn't you go shopping if you were paying the cost? Now, this creates all sorts of havoc and chaos in pricing in the healthcare system. There are reasons it costs that much at the hospital. There are fixed costs in the hospitals. I'm not naive to the economics of it. But if I'm a consumer and I'm paying $600, and you can tell me I basically, either pay it or don't pay it, it's going to make a huge difference to me. This happens to be Schenectady. So Schenectady, New York, basically this is what it costs to get a sore throat. Now, I'm now paying the first $600, so it might not have mattered in that last example because the $600 went either way. Let's say the deductible was $200 in that last example, it would have mattered. Look now, I'm paying the first $1,000 or $600, whatever it is. I can go to my physician, you can see what it costs. I can go to urgent care, or I can go to the ER. But I'm now paying. And so what happens when you go to these high deductible plans is you get a huge kind of emphasis on information. And so this is kind of how we're thinking about it. Look at that side that you have, not the doctor, the patient. The connectiveness is the information. Stuff doesn't work without information. Consumerism doesn't work without information. Again, if you haven't been to that cms.gov site where you look for hospital ratings, it's really worth looking at. They did a nice job. Actually, you can choose 3 hospitals. You can choose Mass General and whatever other hospitals you want in this town or wherever you live, and you can compare them on what's becoming more and more meaningful measurements on quality. They just added complications in-house, and on the private sector, we're going to start adding price, which I'll show you in a minute. Thank you. I'm getting signals. So basically, let me move on and basically talk about high deductible plans. High deductible plans means that instead of paying $15 to see your doc or $50 if you go to the ER, you're going to spend the first $1,000 or $2,000 out of your pocket. This chart, 2012 is on the left, essentially shows what a big movement this is among employers. Your employer might not be doing it yet. It might be an option at this point. But my read of the future, because I believe employers are not going to bail and they're not going to exit, is that these things are going to become the dominant form of insurance over the next decade. So what does that mean? What it means is if you have to pay the dollar, there's a huge demand for information. This is a screenshot. It might not have come over well, but I will walk you through it. It's a company called Castlight. There's a few of these companies. What this company does is essentially allow you with incredibly good interfaces. They hired people from Google, they hired people from Yahoo and Amazon who understand consumer interfaces. This is someone who's searching for basic OBGYN care. You put your zip code in, you find out what network you're in, and you basically say, well, here are the people I can choose from. You basically have some quality stars to the right, and all the methodology is based on who has the best outcomes, who doesn't, and you have actual price. When the health insurance companies do this, they give you the range of 72 to 150. You ever buy a microwave and go to the aggregator site and find a range? I don't think so. I think you find it's $85 here and it's $140 here, etc. That's what these entrepreneurs are doing. So they've hired a bunch of engineers. They go into claims data. They kind of reverse engineer to find out the price, and they say Dr. Smith is $72 and Dr. Jones is $100. And essentially, you now have some information that you've never had before, and people care about it because they're paying first dollar. The next move is going to be not just price information, but it's going to be reference pricing, just like with the drugs, which is a really good doctor in town does it for $130. That's what we employer are paying. You, consumer, can do whatever you want. You can go to the one that's $400, but that'll come out of your pocket and not the corporate pocket. So I'm going to end quickly in the next couple of minutes and just basically say this isn't going to solve the healthcare problem overnight, but it's another example of connection. And I didn't see any booths in the exhibit hall about this, and that's why I was kind of really happy that Joe invited me to speak, because it's the other side of connection. It's well behind what a lot of you folks are doing connectivity-wise, but it's growing like crazy with entrepreneurs like Castlight. The private equity and venture money is moving into it quickly because they're sensing that the other side of connection is consumers and costs, because we have such a cost problem in this country. Look, there are ways that you have to be careful about these high deductibles. No one should ever go bankrupt because of health care. There needs to be means testing or tiering of this stuff, which the smarter companies are doing. We have health literacy issues. You've got to be smart. So I am in no way standing up here saying that this is the answer or a panacea. I'm just telling you there's a trend happening on the other side of the sector, and I think it's pretty interesting, and I think it's going to grow. However, one thing that happens is employees don't necessarily like this. You know, it's kind of a paradigm shift, and shift happens, and people don't like paying more first dollar. So the question is this going to happen? And so I put this slide together and basically said to those who've been around long enough, you think HMOs make people mad? Just wait till they have to pay the first $1,000. But I'd end with this quote, and this is a Bill Gates quote that I happen to like a lot, which is, we always overestimate the change that will occur in the next 2 years, and that did happen with this consumers and high deductible. There were massive predictions about what it would be about 4 or 5 years ago, and it's been slower. But I really like the second clause in this, but we do tend to underestimate the change that will occur in the next 10. Look, my read of the tea leaves is that on the side of the sector I work on, this consumerism thing, this connection thing around cost and particularly price and reference pricing, and all of you and me paying more first dollar is going to surprise us with how big it gets. And with that, thank you.